This lecture will examine assessment of the patient with burn injuries. About 100 or 1.25 million people suffer burns each year. Most of those burns occur in the home, and about 75% of those patients burned are victims that were burned because of their own actions. So the highest risk population burns are young children and the elderly, and part of that is that both of those populations have very fragile and thin skin. One of the main causes of complications and mortality from burns is actually due to infections. When we look at burns, they are often a result of destruction of the skin from either a direct or an indirect thermal type of a force. So some examples could include fire, a scalding from steam or hot liquids, or by touching direct contact with surfaces that have chemicals or electrical current or radiation. So a major burn is going to be accompanied by severe pain, potential for infection and sepsis, and potential for disability, disfigurement, or death. As you all know, the physical effects from burns can be devastating, and the cost can be extremely high in rehabilitation and treatment costs for these particular patients. To review the functions of the skin, remember it's to protect the body, it maintains our body fluids, it helps to maintain temperature control, it's where your sweat and sensory organs are located. So that's why patients that have significant burns will have a lot of pain. It's due to the pain receptors within the skin itself. Patients with third-degree burns sometimes will not have a lot of pain with those third-degree burns because the sensory receptors and nerve endings have actually been so severely damaged. However, most patients that have burns have a mix and a match, if it's significant, of both second and third-degree burns. So burns overall are very painful. When we look at the degree of burn injury, they're broken down into different categories, and these include superficial or first degree, partial thickness or second degree, and full thickness or third degree burns. Please refer to your textbook. There's some pages listed in your speaker notes that talk about characteristics of burns by depth and also classifications of burn injuries. And we're going to go through each of these different burn injuries in some slides in just a couple minutes. This diagram looks at the depth of burn injuries. So it shows the different layers of the skin and where the burn depth would affect the epidermis, the dermis, the muscle, and the bone. So as you can see with patients that suffer third degree full thickness burns, they actually have not only the layers of skin that have been damaged, but also hair follicles, sweat glands, fat, and may extend down with fourth degree burns into muscle and bone layer also. To determine a patient that would come in through the emergency room with a burn, there's some different types of rules that are used to determine what percentage of the body surface area are actually burned on that particular patient. One method that's actually shown here is called the rule of nines, and with this particular type of rule to look at how much is the body surface area that's been affected, you can see on the figures that are shown in the PowerPoint slide what percentage is allocated to different body part types and those types of things. For example, the front side of the leg is 9% of your body surface area. The posterior aspect of the leg is also 9%. So each leg would be 18% of the total body surface area. So when patients come in with splash burns, they're looking at this type of a rule, as well as there's also a method that can be used for patients that may have smaller injuries, and you can actually just get a gross estimation of the percentage of body surface by looking at the patient's palm. If you look at your own palm, that represents about 1% of your body surface area. So if we look at a patient's palm, that would represent 1% of their body surface area. So you can see how a child's palm size would be quite a lot different from an adult size. But that might be a good rule of thumb to use if that patient just suffered some minor burns or burns that were quite scattered throughout the body and those types of things. Remember that the injuries that involve cosmetic and functional areas of the body are going to require longer times to recover because of the physical and emotional reactions to any burns to the face, hands, feet, those types of things. Anytime it's in a joint area, burn care is going to be extensive with physical and occupational therapy needed because of the joint range of motion that needs to be reinstated in those types of things. Remember, any burns to the head, neck, and chest may involve the respiratory tract and can result in respiratory distress and failure. So that would be an issue. And patients that have significant amounts of body surface area burned are going to be at risk for total body infection and sepsis and those types of things. So the first burn that we're going to go through is a first degree or superficial burn. This involves the epidural layer only of the skin, and probably the most common example of this would be, a sunburn. Typically the skin may look red, dry, as a sunburn would, and blistering sometimes is present in first degree burns, and as we all know that they can be quite painful. Here's a picture of a woman that has sustained a pretty significant sunburn. So it's typically these first degree burns will heal on their own in usually about a 3 to 5 day period. Partial thickness or second degree burns have destruction of the epidermis and varying levels of the dermis also. They're typically very painful. Blister formation is very common, and healing takes a little bit longer, usually 2 to 4 weeks to heal a second degree burn. The skin usually is quite red. Blisters are often present, and they may increase in size because of continuous exudation and collection of tissue fluid. So hair follicles typically remain intact with a second degree burn, but there may be longer healing times just depending on the depth of the burn, and there may be some scarring. This is an example of a partial thickness burn. You can see how the area of the skin is red and shiny, and above the shiny area is actually some exudate area. This is where the epidermis has been removed, exposing the dermis underneath. So the white area from the wrist on down is a deeper partial thickness burn that this patient has actually sustained. Third or fourth degree burns are known as full thickness burns. This is where there's been destruction of the epidermis, dermis, and possibly subcutaneous tissue, muscle, and also bone. These are typically painless until those nerve cells start to regenerate, and then it becomes painful. There's formation of eschar with these, which is where the wound is actually looking leathery. It's the deadened skin area. And these types of burns will require skin grafting because the epithelial tissue has been destroyed and is unable to regenerate. So risks with a third degree burn include infection, decreased blood supply, so the risk for poor circulation and those types of things. Patients that have a significant amount of body surface area that has a third degree burn on it will be at risk for shock, hematuria, hemolysis, and infection. And these burns with significant body surface area affected carry quite a high mortality rate. Typically, a major burn is certified as any third degree burn over 10% of the body. That's considered a major injury. Or second degree burns over 25% of the body surface area in an adult and over 20% of the body surface area in a child are considered major injuries. And then also any burns of the eyes, ears, face, hands, feet, joints, and perineum are considered major burn injuries, as are all inhalation burns. So refer to your textbook. There's a great chart that looks at classifications of burn injuries. This slide looks at some pictures of full thickness burns. You can note the whitened areas, the lack of hair. This indicates full thickness burn, and muscle involvement is also involved in those photos in the right side. This talks about eschar and eschorotomies. eschar is that leathery covering that's composed of denaturated proteins. It forms as a result of surface dehydration, and what happens with this is it can actually cause almost a compartment syndrome type of a situation where that skin does not expand anymore, and when this patient starts to have fluid accumulation due to damaged capillaries and those types of things, can actually, the skin, because it's that eschar, can cut off circulation to the body part. So one way to relieve that pressure and allow better circulation to that body part is to perform an escharotomy, which is actually where the physician uses a scalpel to make an incision along the skin, and that allows that tissue to expand and decreases pressure on the underlying structures. So the skin will spread, as you can see in that picture there. That's a chest escharotomy being done for a chest burn. The skin will spread apart after this is done, but it will restore circulation to the burned area of the body, and that's what the whole point of it is. So, of course, two big issues with having this procedure done would be to control bleeding and also risk for infection after that's done. Typically, the site will be covered in dressings that will help to control bleeding and also to control all the exudate and drainage that comes from that particular site. The body's response to burn injury can be quite significant. You can read through your speaker notes to see how the body actually responds, not only locally but also systemically, and all the body systems are also impacted by burns. So please read through the speaker notes to find all the different issues that occur with that patient that's had systemic body surface area involvement. Typically, we say when the patient's had more than 25% of the body surface area affected by a burn, the fluid will start to shift from the intravascular to interstitial spaces. And that's what leads to the hemodynamic instability, hypoperfusion to the lungs, to the kidneys, to the brain, to those different areas, and also the problems that arise because of all of that. So remember, pulmonary can be from poor perfusion. You can have issues, or the patient may have also had smoke inhalation, which can lead to adult respiratory distress syndrome and poor pulmonary function and those types of things. Patients are at risk with bowel for not only a paralytic ileus, but also for gastric and duodenal ulcers due to the stress of the burn, and that's actually considered called a Curling's type of an ulcer. That's a stress ulcer. And so patients are typically put on H2 blockers and enteral feedings to try to combat complications from that. And we've already talked about immune issues, bone marrow depression, decreased immunoglobulin production, and all those types of things makes that patient, and just the fact that they don't have skin there as a type of immune basis can lead them to higher risk for overwhelming sepsis. Burn complications include all of these things listed here. Patients can have fluid volume issues, electrolyte imbalances. We've talked about ARDS and renal compromise issues. Patients may also have damage to the liver, and of course psychological disturbances due to pain and also disfigurement from the burns. Typically, like we said, infection is one major cause of mortality. Patients may not be given an antibiotic prophylactically. It depends on what their situation is, and it depends on physician preference because of the risk of developing resistant strains to organisms. Typically, regular tissue cultures are going to be taken and then ordered if the patient develops some sort of a wound management. Immediate burn management care is going to include ABCs, and then also care with DEF, and D stands for dysrhythmias and disabilities, E stands for exposure to the burn, and F stands for fluid resuscitation. So patients are given pain medications typically in the IV form. Fentanyl and morphine are commonly given for pain relief. Meperidine or Demerol is not given very often because of the risks of buildup and high levels of that within the tissues and that type of a thing. Patients may need a prophylactic tetanus booster if they've not had one within the past 5 to 10 years. And in order to give large volumes of IV fluids, patients a lot of times will require large bore needles such as a central venous line placement, Swan-Ganz catheter, PICC line, that type of a thing for fluid placement. Usually patients are started initially on lactated ringers. That should be started within an hour of when the patient's brought in for treatment from a burn, and this will help to prevent hypovolemic shock on the patient. They need to be monitored very closely for intake and output, so they'll have a Foley with an hourly urimeter on it, NG placement, and if the patient has respiratory complications, they'll also require ET tube and ventilatory support for that also. Your book talks about 3 different stages in burn care, and the first stage is referred to as the emergent or resuscitative stage. This is also known as the burn shock or hypovolemic stage. This occurs up to 48 to 72 hours after the first initial burn injury, and it lasts from the onset of the burn injury through successful fluid resuscitation for that patient. What you have going on in here are capillaries that have been damaged from the burn, and because of this capillary damage, the fluid shifts from the vascular area to the interstitial area, which leads to a lot of blistering and edema in the burned area for that patient, and electrolyte disturbances because of those fluid shifts and that type of a thing. So the body responds by going into peripheral vasoconstriction, which leads to poor renal perfusion and perfusion problems to the vital organs. So these patients need to have fluid resuscitation started as soon as possible to try to bring that the overall fluid status back to a normal state. Typically this whole stage will last about 48 to 72 hours until the capillary integrity is restored and the blood starts to get back into the vascular space again. So remember, because of the capillary permeability increasing, you're going to have sodium and water shifts from the intervascular to the interstitial spaces, and this can actually decrease the circulating blood volume by almost 50%. You'll also have cell lysis due to the burn injury and capillaries being injured, which can lead to hyperkalemia and also hemoglobin and myoglobin in the urine. And you'll have the adrenal glands releasing hormones and catecholamines in response to the stress on the body, which can lead to vasoconstriction, tachycardia, elevated glucose levels, and those types of things. So until those capillaries regain their integrity and the patient's fluid status returns back to normal, the patient's at high risk for being in shock. To give fluids back for that patient, there's some formulas that are actually used, and your book talks about a couple of them. One is called the Brook and Parkland formula, and with this formula, patients actually receive 4 milliliters of lactated ringers times their body weight in kilograms times the percent of body surface area that's actually been burned, and they'll get that amount of fluid back within 24 hours. Half of that amount is given in the first 8 hours, and then the other half of that is given in the next 16 hours of the day. So just to show you an example of that, if you had a 130-pound patient, that would be equivalent to 59 kilograms. If you multiplied 4 times 59 times, let's say that patient was burned over 40% of the body surface area, that would mean that patient's going to receive 9,440 milliliters of fluid in that first 24 hours. And remember, half of that amount is given in the first 8 hours. So that patient's IV rate would go at 590 milliliters an hour for the first 8 hours. And then they'd get the other half of the fluid in the next 16 hours, which would run the IV at 295 milliliters per hour. So as you can see, these patients need those central venous catheters or PICC lines or Swan-Ganz in order to run this large amount of fluid in over quickly. For also besides lactated ringers, hypertonic fluids such as 0.9 normal saline pull fluid from the interstitial space back into the intravascular space. But probably the most common fluid used is, as we talked about earlier, lactated ringers. After that initial 24-hour period, then the patient can start to receive colloids such as albumin and dextran, which will help to increase the vascular space, and then also fresh frozen plasma after 24 hours, and blood as needed and those types of things. Remember, urine output is going to be measured hourly so that we can make sure the patient has good renal perfusion and doesn't end up with kidney damage. And our goal is to try and have that urine output between 30 and 50 milliliters per hour. After that initial emergent phase is completed, then the patient goes into what we call the acute stage, which is also known as the diuretic stage. This actually begins with the start of diuresis and ends with the closure of the burn wound. So this typically will occur 48 to 72 hours after the severe burn. The capillaries have now started to repair themselves, so the fluid can now shift back from the interstitial space back to the vascular area. And the issue here now is that the patient's at risk for fluid overload as all that fluid shifts back to the vascular area. So we change the fluids then to typically D5.9 normal saline and run it at a slower IV rate, more at just a maintenance type of a rate. So just to kind of give you a basic rule of thumb, a patient with a 40% body surface area burn injury will require about 40 days for that burn to be in these initial healing stages. That patient may actually be in treatment for up to several months or years, depending on contractures, the area of the body that was affected by the burn, and how many multiple surgeries that they need to go to with skin grafting and relieving pressure on joints and those types of things. But that just gives you a rule of thumb, so you know how long that patient might be expected to be back in a burn setting, in a burn unit for that type of a thing. This talks about calls for nursing or nursing diagnoses in that first emergent resuscitative stage, ineffective airway clearance, hypothermia. Patients' burns units are typically, their rooms are kept very warm, usually above 80 degrees to eliminate drafts. The patients may sometimes be put under heat lamps and fluid warmers, have warming blankets, and the wounds are covered to try and keep that patient warm, because remember, they don't have that defense of the skin keeping them warm. They're also at risk for altered fluid volume status, and we just talked about that. They're at risk for infection, problems with tissue perfusion due to circulatory compromise, and compartment syndrome. Remember, we talked about the escharotomy earlier. Pain is going to be an issue because they're going to be going through daily debridements and dressing changes and things that are very, very painful for a patient that's had a severe burn. Typically, these patients will have an PCA pump with morphine. Fentanyl is also sometimes given very commonly. And many of these burn units will also use complementary therapies with patients, such as meditation, guided imagery, music therapy, and massage to the non-injured areas to try and help with pain control. Some units actually will even use nitrous oxide during the debridements and things like that. So patients have issues also with anxiety, so they're given lots of psychological support. Management during the acute phase also includes lots of diagnostic tests to check for fluid and electrolyte balance, CBC to check for those elevations in white blood cell count, chem profiles to look at liver function, renal function, cardiac function, those types of things, wound cultures on a routine basis to make sure the patient isn't getting sepsis, blood cultures, and also looking at albumin and nutritional labs to look at that patient's overall nutritional status. And the patient may also require bronchoscopy if they are worried about some sort of respiratory involvement with their burn. We've talked about analgesic medications being used, and also H2 blockers to try to prevent stomach ulcers. So the patient will typically be on Zantac, Tagamet, those types of meds, steroids, and topical antimicrobial agents and enzyme topical ointments to help remove with the eschar and those types of things. So please see your textbook for topical meds that patients are typically on when they've had severe burns. Skin grafting we're going to talk about in the next few slides, and that's one of the treatment modalities for patients with significant burns. And patients, remember, will need high-calorie diets because typically the calorie intake needs to be double what the patient took before, if not even higher. Many times patients will need between 3,500 and 5,000 calories a day for regeneration of skin, muscle, bone, and all the tissue that has been damaged. So patients are typically given a very high protein diet with vitamin and mineral supplements. Typically vitamin C, A, zinc, and E are included with their vitamin supplements. Remember, the patients will be in a negative nitrogen balance, so that's why they need extra protein. And as we said before, they may need vitamin and mineral supplements up to 2 to 3 times the recommended daily dose by the FDA, just because of their metabolism being so increased during this healing phase. This slide looks at different types of grafts that are used for patients that have burn injuries. An autograft is when the patient's own unburned skin is removed and applied to the burn wound. An allograft is actually a skin graft that's obtained from a cadaver. We get these from tissue banks, and this is used to cover deep or partial thickness wounds that enables the blood supply to regenerate. It does carry some risk, however, for disease transmission. Typically the cadaver skin is harvested within 6 to 12 hours after the patient has died, and then it's sent to a tissue or skin bank. Heterograft is actually skin obtained from another species. For example, pig skin is often used, and this protects the wound while permanent options are being examined. So typically that would just buy some time. There are some also synthetic dressings that are on the market. BioBrain is one example of that. It's actually a nylon and celastin and collagen type of a derivative, and that can be used over the donor site or burn site. It's very expensive type of material. And then there are also lots of dermal replacement types of products that are out there, such as Integra, which is a celastin animal collagen, Alloderm, which is a human cadaver allograft dermis that's non-immunogenic, and a new one that's on the market is called Apligraph, which is actually skin cells that are cultured from neonatal foreskin. So your book also talks about a VAC, which is a vacuum type of a unit that's used with patients with burns. So see your textbook to look for some more information with that. This just shows you some different types of grafts that are used. Split thickness grafts versus full thickness skin grafts. With a split thickness skin graft, that includes the upper layers of the epidermis down through part of the dermis. And the donor site where it's removed from, if the deeper layers of the skin are taken, the skin at the donor site will not regenerate. So typically grafts are removed from almost any unburned area of the body, and they're used as sheets in like a meshing type of a graft so that they can cover larger areas. The meshing almost makes the skin look kind of porous, almost like a screen would look, and this can increase the donor site area that can be covered, or I should say the burn site, by up to 9 times the original donor site skin size. Full thickness skin grafts are composed of layers of skin down to the sub-Q tissue, and they're used for areas of full thickness burns. They typically give a better cosmetic appearance, and also areas that benefit from full thickness skin grafts would be the hands, the neck, and the face. So they will help to restore body function and help with skin contractures and those types of things. These are some pictures of skin grafting. The picture to the right is what I was describing earlier, when you can actually get a weave kind of a pattern so you can cover more surface area from That's actually skin from a donor site that's being held there on that right picture. And then this just shows to the left what the donor site would look at. So in other words, the top layers of the skin were removed from the thigh on a patient that had been burned in another area of the body. The donor site, actually, if you look at it, almost looks like a burn. It's very reddened, and it's very painful until it heals. Usually it takes about 2 weeks for that donor site to actually heal. And another option also for patients that's kind of new on the horizon is that they are now taking cultured epithelial autografting, which is where skin cells are removed from unburned areas of the body and then put in a culture medium and then grown in a lab. The nice thing about this is that over 5 to 7 days, those cells can expand up to 50 to 70 times their original size. And within about a 1-month period of time, there's going to be enough skin in those cells to cover an entire body. So the patient would need to have some sort of synthetic grafting in the meantime, or something to cover that burn site. Here are some pictures of some donor sites. The one listed down on the left-hand side shows a donor site where skin has been removed and then is covered with BioBrain until that skin can regenerate again. In the right-hand column is a donor site covered with a Xeroform type of a dressing, and then one on the right lower part shows a donor site covered with Tegaderm. Xeroform is actually a gauze that's covered in a petroleum jelly type of a product. So, and if the patient doesn't have a suitable donor site on the body, let's say if they had such extensive burns that they really didn't have any area on that patient's body that they could take skin from, then the patient would have to get the homograft skin graft from a skin bank, or use, as we talked about earlier, pig skin or something like that. So the whole goal of skin grafting is to speed the healing of the burned area, to prevent contractures, and to shorten that patient's convalescent period. So this is just another example here of healing in a grafted site versus healing donor site area. So you can see the differences between the left and the right. So eventually that grafted site will granulate new tissue, and the donor site will grow back that epithelial layer that was taken from that particular area. As far as interventions for the skin graft sites, it's very important that those skin grafts are not displaced. They're very, very delicate. They can change position easily. So patients will be immobilized and have immobilizers on an area if it's an extremity that's had a skin graft put on. And it's very important that those splints stay on the skin graft site until they're removed by the physician. So typically that's going to be for about 5 to 7 days. There's going to be dressings that cover the skin grafting site, and those are going to stay on until the physician removes those. And some problems that can happen is sometimes there can be fluid accumulation under those skin graft sites. So they are checked. Typically the physician, when they do rounds, will remove those dressings, looked at the skin graft site every day to see how they're looking. If there is fluid accumulation, there can be aspiration of that fluid by putting a needle down in that area, or by rolling the area with like a cotton tip to drain off some of the fluid. And the graft dressings, of course, are removed very carefully so that the skin graft is not dislodged or shifted or moved. So these patients have no range of motion on that graft site until about 5 days post-op after the skin grafting has been done. And like I said, the dressing is looked at daily. The actual graft site is looked at daily to make sure that everything is taking okay, no signs of infection or complications. Care of wounds and debridement. Typically many different topical medications are going to be used on burn therapy patients. So remember, these patients undergo lots of treatment types of things to help with their wound coverage. Hydrotherapy, showers, baths, things like that will help to remove the dead tissue. They get mechanical debridement, either through a shower or different scrubbing, that type of a thing, 1 to 2 times every day to get all that dead tissue off, because remember, new tissue can't grow until the dead tissue has all been removed. So patients are immersed in tubs, showered on specially designed shower tables, or washed if there's a small area at the bedside. And then topical enzyme agents are used to help with wound debridement also. These enzymes like santinil will actually digest the collagen that's in the necrotic tissue so that new tissue can regenerate. And remember, patients can lose up to about 100 milliliters of blood for every 1% of body surface area that is excised. So we need to keep a close eye on their H&H status to make sure that they're not getting anemic or anything like that. So calls for nursing for patients while they're undergoing these skin grafts in the acute phase is impaired tissue integrity. There's a huge risk for infection. We talked about that negative nitrogen balance, so impaired nutrition is going to be an issue. As you can imagine, with debridement and showers and dressing changes with a severe burn, there's going to be acute pain. Patients are going to have issues with mobility, fluid volume issues, and body image and coping is going to be a issue for these patients also. During the rehabilitative stage, this actually occurs after the wound closure and ends when it begins with wound closure and it ends when the client has returned to the highest level of health restoration. The goal is to try and get that patient capable of assuming self-care activities and to get them reintegrated back into their home life, their work and social aspects, and try to get them back to where they were before they actually had the burn injury occur. So patients will have lots of issues with this rehabilitation stage, such as post-traumatic stress disorder symptoms, fears, coping issues. They may have vocational issues if they can't return to their same job due to their the problems and issues and complications that they've had from their severe burn injury. One of the goals is to try to restore function over scarred joint surfaces if the patient has had burns in those types of areas. So the rehabilitation stage for some patients can actually take months to years, depending on how many times they have to go in for repeated surgeries, physical therapy, occupational therapy, those types of things. One thing that does help during that rehabilitation stage is the use of compression garments. These are a specialized elastic woven material that patients actually wear to minimize scarring. They wear these 23 hours a day for up to 6 months to a year after they've had their burn. And the issues with it is, of course, they would be very hot, they're tight, they're uncomfortable, but they do help with disfigurement and for a better look with the skin grafting and those types of things. Discharge planning with these patients is going to include all of those things listed, getting physical therapy involved for range of motion and exercise and ambulation assistance, splinting extremities as needed, compression garments, pain management, and emotional support, and trying to get them into family and support and different things like that are going to be very important. Probably one of the best things that we can do as nurses is to do educational programs to try and keep burns from preventing in the first place. If you remember back to the original slide, we noted that 75% of patients that were burned because of their own actions. So trying to get educational programs done and burn awareness campaigns are going to be helpful. Things as simple as just making sure patients have smoke alarms installed in the home, that they're in good working order, that families do fire drills in case of a fire so small children would know how to get out of the house, where to meet parents, those types of things. Trying to make sure that kids and adults have flame retardant clothing and fabrics on, especially with pajamas. And make sure patients know to label chemicals that could cause burns, no antidotes, no poison control, to call to find out what to do, those kinds of issues. And then on your speaker notes are some other just common sense ideas as far as prevention strategies also, as far as to prevent burn injuries. And this concludes the burn lecture.